All right. I am pleased to introduce Dr. Brad Tinkle, a clinical geneticist at Peyton Manning Children's Hospital. Dr. Tinkle serves mostly the connective tissue population, including bone disorders, Marfan syndrome, hypermobility spectrum, Ehlers-Danlos syndromes, and other heritable connective tissue disorders. He currently sees 25 to 30 connective tissue patients weekly of all ages for one of the largest such clinics in North America.
Thank you. Hopefully everybody can hear me. This is going to be somewhat superficial just because we're covering a broad span of different things. So as you heard, my talk, joint hypermobility throughout life. A little bit you had already heard, basically, I see roughly 25 to 35 patients a week. I've done this for 20 years. So I see mostly just connective tissue, joint hypermobility related stuff. That's probably 90 to 95% of the population that I see. I'm kind of, I call it generalist. Obviously, I'm not a surgeon. I'm not a GI person that does procedures and whatever else. So part of what I do is manage overall, but there's still quite a bit that I do manage myself. The one unique thing about genetics is that most time we see and get involved in with families. So because of that, even though I'm at a children's hospital, I do see adults. And the nice thing about the lifespan is I see basically we have all kinds of discussion pre-conception, prenatally, about the infant, how the mother does during the pregnancy, through children, young adults, to the very old. My oldest patient currently is 84. You're all familiar with the Beighton score, I'm sure, but there are things about the Beighton score that we do have to take in consideration. I think you heard a little bit about that in a question and answer session of how we might modify some things, but I wanted to give you a little different perspective. So the top two are basically studies in India, where they did look at children, same age group, so pretty comparable populations. But if you use a Beighton score of 4, you got 60%. If you use Beighton score of 5, you got 40%, sorry. So obviously, what do you call hypermobility? What do you call hypermobility? Is this something that's normal or not with 60% or 40%? And obviously in that population, would you change the threshold? Sekin did another study in Turkish, but it wasn't all age children, it was adolescents. And you can see there they got nearly 12% for Beighton score of 4 and 4.5 for Beighton score of 5. So how we set that threshold can make a difference. It can make a difference based on age, potentially ethnicity, gender. So yes, we don't necessarily have the most precise way of doing that, but the current standards right now is to prepubertal children down to 6, we suggest a score of 6, whereas from pubertal to 50, score of 5, and 15 and beyond 4. Now, anybody who does apply this should know there are certain caveats. For example, if you could put your hand flat on the floor and it's just the palm is just a little bit above, I'm going to take that in consideration. It's a plus minus score, but just things you got to keep in mind. And so we do have a little bit of wiggle room to what we call joint hypermobility. This was a study very similar to what you heard about the looking at knee injuries in females, but also the hormonal components. And in the place where I started my career off, they basically wanted to look at that too. So they did want to look at the hypermobility as part of the injury risk profile. And they recruited, this is where they got several thousand patients as they offered their pre-participation sports physical for anybody who would come in. So they actually gathered quite a bit of information. They would literally drive school buses to the place. And so the interesting point was, if you looked at prepubertal, this is the general population, that there was not a statistically significant difference between males and females. But once you hit puberty, there was a definite difference between them. This, of course, mirrors why we think that something pubertal happens. Typically, the thought process is hormones, but obviously we still need more work to find out how this goes. This is from Castori, where there's 2 other studies, but in general, just looking at the Beighton score relative to like average age. And obviously, as been said several times, we get stiffer with age. So the Beighton score is likely to change with age. Why we chose 50 as a number versus doing studies like this and saying, well, if 5 is a score, you know, that through the lines is kind of more average, or 35 to 40, how come we didn't use those numbers? And again, not great studies. We want everybody, but at the same time, we wanted to make sure that we understand this a little bit more and not be so strict about that cutoff number. Early childhood. There's several things that I see. Risk for congenital hip dysplasia is something we want to pay attention to, because I don't like replacing my hips in my 25-year-olds, but it does happen. So looseness of the hip joints we take fairly seriously. There's not a lot during childhood, but as they age, the looseness can cause damage to the joint. And so we want to be aware of that ahead of time and do like hip preservation type stuff before we consider hip replacements. I've seen several people say development milestones are off in people with hypermobility, and I wholeheartedly disagree with that. The vast majority of mine have normal development milestones. The problem is they're not very good at some of those tasks. They may walk on time, but their coordination and clumsiness means they're not necessarily good walkers when they walk on time. When they do walk, toddlers bump into everything. They hit the table, chairs, whatever else. So they typically have a bruising pattern across the shin, knees, elbows, and forehead. And so the typical bruising pattern is still common in people with hypermobility, but we tend to see more of it. And sometimes that begs the question of, did somebody harm this child? But it still should be in the typical pattern. Chronic constipation, probably there from the very beginning. It is one of those things that I don't think most families would appreciate until at least toilet training. But it is one of those things that we feel really is there. And so it is one of those things that we have to sort of consider along the way. And unfortunately, it doesn't go away. You learn how to treat it, but it doesn't go away automatically. The elbow dislocation, kind of interesting. There's the nursemaid's elbow, where the little toddler throws a fit and gets to the ground, the elbow pulls because you're holding the hand. Hager said there's not an increased incidence, which if you think of hypermobility and maybe dislocations, et cetera, you would think that there's more that should happen. But I would actually agree with that study. I don't see more happening across the population. What I see is when they have it, they have 5, 6, 7 different dislocations. I do not know why somebody doesn't stop and go, something's different about that child, but it's kind of perplexes me when I hear it all the time. 3 to 6, this is when they're moving a little bit more, maybe they get involved in activities, but even sort of the daytime activities, going out and play, sometimes they're much more fatigable. So they may nap a little bit more, they may not. So, you know, Mommy, I want to go to the park, and then an hour into the park, it's just like, I'm done, and everybody else is still playing, kind of thing. So we see that. We still see the clumsiness and the constipation as they can start to voice different things. Unfortunately, when they get potty trained, parents don't necessarily always pay attention to their bowel movements or whatever else. So sometimes they don't know at this age they're having hard, painful stools, and sometimes they just have avoidance. I don't want to go to the bathroom because it hurts. And so that just builds up continued problems. When we get into the school years, a lot of them are still happy contortionists. It doesn't hurt so much to bend your body in a pretzel. And so most time parents, doctors don't think of it Because many times it's like, oh yeah, she's shown the doctor many times how she can do stuff, and they say that's not normal. But again, they're not thinking that. Activity-related pains, for somebody who is loose jointed, it does take more muscle control, and therefore it takes more muscle activity to do the same things, which means then the muscle fatigues quicker. And so they often have growing pains or nocturnal pains at night. It's typically not growing pains because they're not growing. You can almost, my summer months, most of my kids are complaining of pain. They're not so much during the school because they're not as free playing and stuff as they would in the summer. This is also, we start to see much more fine motor skills, many joints in the hands, you still have to control. So sometimes, they can write fine, but the poor endurance and fatigability means they can't necessarily keep up with it. Sometimes that causes conflicts in the school where the teacher goes, I know you can do good work, but they see the 2 o'clock work and the handwriting looks like a doctor's handwriting. Just terrible. The flat-footed is technically your arch develops until about 6 years of age. However, definitely in the 3, 4, 5, 6-year-olds, if it's not developing and it's further collapsing, then obviously I'm going to treat it. But definitely after 6, if you see that collapsible flat foot, and especially if you start to see the heel valgus, I don't know if I can control this either. I'm trying. Anyway, here, it's better. You see the angle here? So you want that foot underneath the ankle to give support to the ankle. When it's at an odd angle, more muscles strain to support that, and it will strain all the way up to the lower back. And so it is a common cause, especially in adolescents, of chronic low back pain. So we want to pay attention to that and help support that if we can. Teenagers, sometimes they're the most fun, but also the most challenging group. This is when the musculoskeletal pains become more in earnest. They may have activity pains, but a lot of them start developing that chronic pain. This is also where they diverge. Males seem to be much better. Females tend to have more issues. We start seeing chronic pain and features consistent with fibromyalgia. Headaches, especially postural-related muscle tension headaches, are more common just because they're looking down, and the electronics we do these days are just much more horrible for them, for all of us, really. The clumsiness is still there. Now they're bigger folks, so if they're still clumsy, that means much more energy when they fall. Again, more injury risk, not just to the individual joint, but to falling, breaking a nose, catching yourself, breaking a wrist, something like that. And then the frank instability of the joints and the pressure on the other soft tissue. So sometimes we see a lot of itises, bursitis, tendonitis, and et cetera, because the joint is loose, but it's stressing some of those other tissues first. Anxiety, you've heard quite a bit about. It is something that's very common in this population. Sometimes it does translate to kinesiophobia. Sometimes that's more unconscious. They just don't like to do things because it hurts. Other times I will hear them specifically say, I will not walk up the stairs because my knee tends to buckle. And that's just it. I just won't do that. Whoops. I went backwards. Okay. So it is one of those things, and you see anxiety, depression. Anybody with a chronic medical condition tends to have that burden. It is one of the things I do tell a lot of them. Your psychological and emotional state's also very important. It's important to your physical health, and your physical health is important for that state as well. But too many of them have been gaslit or some other things just not believed, and so they get very offended if I bring up psychological things, especially on the first visit. But I do try to tell them that these are things you need to take care of. Cognitive behavior therapy works for a lot of this stuff. So finding a good mental health professional is helpful. Constipation, again, teenagers tend to not necessarily talk about their poop or whatever else. And so it is one of those things that usually show up more in more abdominal pain and those kinds of things. So we need to actually, again, help them manage it. The dysautonomia, I'll talk a little bit more. You've already heard about that though. The fatigue, you've also already heard that's multifactorial, a lot of things going on that sort of zap your energy level. And heavy menstrual bleeding is fairly common. It's just like the prolonged bleeding, easy bruising part. So we see a lot of teenagers with very heavy periods. That puts them at risk for anemia, which doesn't help both the fatigue, the dysautonomia stuff. So we want to help them manage that. Most time it's hormonal control stuff, but that's a subject that it's a little bit more complicated with religion and other preferences. It's going to get more complicated in the States here soon. So the dysautonomia, you probably have seen a lot of this list. The lightheadedness, so standing up, getting lightheaded, nearly passing out or passing out. You get the reaction of your heart beating harder and faster. That can cause a pulsing headache for a lot of people, changes their vision. Not only do you see blackness, but even afterwards, your pupils dilate. And so that can become light sensitive. So along with that pounding headache and the light sensitivity, they usually describe as migraines. Some of the typical medicines for migraines don't work as well. So most time we're dealing with the headaches, it's either the dysautonomia stuff or it's the tension stuff and not necessarily true migraine. Chest pain, tightness, shakiness, headaches, stomach pain, bloating, nausea, the poor cognition we heard quite a bit about, the temperature control issues, all we're starting to see them at this age. And sometimes they're just so surprised because nobody's ever asked these questions. And even about the lightheadedness and dizziness, how many people come in with low blood pressure and they'll say, oh, the nurse comments my blood pressure is really low all the time and et cetera. So did anybody ask if something happens when you stand up? No, never did. The sleep pain, depression, we could draw little circles and diagrams for many different things, but there's a lot of things that interact with other things. And so it is hard to take a set of symptoms in people with hypermobility and say, we'll fix this and ignore everything else because they'll feed off another. So if you have sleep problems, fatigability, and et cetera, you're probably going to be grouchy. You're not going to have the energy. You're probably not going to do the exercises I want you to do. And that cycle just continues. Pain's a big component of that, but we can name the dysautonomia and the GI stuff. You're supposed to be drinking to help your dysautonomia and your GI tolerance. But then if you're too nauseated, you want to drink. Those are the people who go spiral down the drain that I'm having to put feeding tubes in. Posture is one thing. Most of us could use better support when it comes to that, but we do want to teach them as young individuals mechanics of how they do things, how they sit, how they stand, and how they do their activities is very important. And this was a slide that I would have been probably great for you to have when you were explaining, looking at the exercise and seeing the young lady doing the same pull down, but now in hyperextension. So we do focus on these things, both in their exercise program and the ones who want to stay active in a sport, because a lot of times I will put them with a sports therapist to make sure the mechanics of what they do is correct. If you're throwing or whatever else, I've seen too many promising pitchers who end up burning through their elbow because they constantly hyperextend. And we can teach them out of it. I have a music therapist, a dance therapist. I have all kinds of therapists for different activities. It's just a matter of getting them plugged in. Early adulthood. Young adults are also a little challenging. Their life has changed. Went from a very structured school system to maybe college, maybe work. There's some structure to it, but now they get to choose what they want to do and et cetera. So sometimes it's that boom or bust. I'm going to be the weekend athlete and go to work. I'm going to go out and drinking all weekend and et cetera, dehydrate myself. So those are things that we have to sort of deal with and kind of talk about that balance of what they're doing and concentration on their health. Most typical young adults don't think too much about their health. Unfortunately, it's one of the things that we have to get them to think about it and be somewhat selfish about it. and even though they want to socialize and et cetera. The jaw issues are kind of perplexing. It should be there all along, but I don't hear too many teenagers complain about it. Not sure why. I've threatened to wire the jaws of a couple of teenagers, but they're like, fine. I don't need to talk to anybody. I'm on my phone. Okay, so deflated my balloon. You can tell I've had a couple of kids. So it is one of those things that we see jaw laxity, because the jaw is obviously another joint. So that can lead to headaches, but a lot of stuff that's happening through the back here will contribute to the jaw issues. And so this is another healthcare professional group that we have to bring in. You've heard about the local anesthetics that may be dentists, but now we have the orthodontist or the oral maxillofacial surgeon or whatever else. The jaw joint's a little bit more tricky. It has a piece of cartilage that floats, and so you can dislocate it and relocate, and that cartilage could be dislocated. And so I've seen some that have bad osteoarthritis because they've dislocated their TMJ disc, but they've relocated their jaw. So education about that, education for the dental health professionals, also important. Other joint issues, depends on what you're doing. So obviously, if you're doing things, you have an occupation where you stand all the time, they may complain more about the knee and hip issues, back issues. If you're working on a computer, doing other things, we gotta support that. A lot of times we're doing accommodations at work to try to break up some of those repetitive activities and et cetera. So we do a lot of school and workplace accommodations to sort of help them out. And pregnancy for young adults is always a question. Pregnancy can be tolerated pretty well, but you still have some challenges. What I try to remind most of my parents, and they think, oh, pregnancy is 9 months, I'll get through it, no problem. It's like, yes, but you gotta take care of that child. And that child sits on a hip or whatever else, and you're carrying the diaper bag and et cetera. So motherhood becomes a very physical job. So I asked them to think about it, do the best for planning to make sure that they have some way of getting some relief. They can take care of themselves. So they're sharing things with a partner or somebody else to take that physical burden off them. Middle adulthood, I put this picture up here because early in my career, there was, as a geneticist, we're pediatric trained, we think of things mostly in that perspective. And so we were diagnosing EDS with about anybody who was almost hypermobile and who might have some other problems. But sometimes they were the happy contortionists. Yet the parents would be the people who would go, that was me. And now I'm aching, I'm sore all over, and all this other stuff is happening. And so they may not have still be hypermobile. So what did we call them? And fortunately, I started working with some rheumatologists, and they asked a very blank question: what's the difference? Of course, I turned to my mentor. Hey, what's the difference? Like, I don't know. But I think we quickly found out that the children I saw had parents like them. And so we started that dialogue back and forth and realized that what was being called joint hypermobility syndrome was probably the same as the people with hypermobile EDS. And so Dr. Castori did some studies, I did some studies. It's kind of the blind men describing the elephant. You're describing the same problem from different perspectives. I put this up here just because I just introduced the joint hypermobility syndrome, and they have a separate set of literature with now thankfully we've combined together. But when they were publishing what are some of the issues, you can see pain being one of the biggest ones, fatigue, sleep problems, anxiety, depression, syncope, some of the other dysautonomias. They pretty much overlaid what we were describing hypermobility. So it was a very, it melded together. We didn't have a lot of things to explain, maybe some potential differences between the two. Actually, in my adults, I like this term. I tend to use that diagnosis more than I do hypermobile spectrum or hypermobile EDS for different reasons. Pelvic floor dysfunction, time you've had pregnancy, time you've had some mileage on your body, time you might put on weight or whatever else. So that's something else that we deal a lot with. So pre-pregnancy, we also, even if it's your first pregnancy, we plan pelvic floor therapy. I may send them to general therapy, and the thing that I send them next, a lot of times, is pelvic floor therapy, even if they're not complaining. I want them to have the right tools they can help take care of themselves and not wait till things become a problem. Late adulthood gets to be the problems have occurred, now we're dealing with the problems. We're either dealing with the pelvic prolapse or other things. We're dealing with osteoarthritis, spine, hips, knees. We're also dealing with sometimes multiple surgeries. I've had some come in with, on the last one I had like last week, this was over 60 surgeries. And it's like, I can help with hypermobility, but now you've caused so much damage to fix things. You're now treating those damages, not so much the hypermobility. So we look at those longer term consequences of things, and we try to make sure the surgeries are done preferentially and not a knee-jerk reaction. Because too many people will tell you that the surgeries, if not done properly and not taking care of the chronic problems underneath, a lot of times don't end the results that you want them to. And then people asked about menopause, so I'll mention that very briefly. Because of the hormonal changes, I do see a fluctuation of symptoms, more dysautonomia symptoms, because they also have that vasomotor, the typical for menopause. So I get a lot of them complaining a lot more of the lightheadedness and dizziness that we have to take care of. Their joint issues, I don't think change too much. It's just more achiness. Of course, when you have like dysautonomia that's out of control, you just feel bad anyhow. So we try to get them through menopause as minimally with symptoms as possible, but most of our treatment's the same. Definitely for arthritis, we want them to be moving and functional, because that's ultimately our goal for anybody, is to be more functional. We may not be the greatest at reducing pain, but a lot of times when I reduce pain, people start to do more and their pain increases. So I always got fooled, and I would always almost throw down my clipboard, whatever else. I was like, oh, I was a 6 out of 10. Okay, how you doing now? 6. What are we doing wrong? Are you not doing the exercises? You know, like any parent accusing them of not following through, and come to find out they were happier. Why are you happier? I'm going out with my friends. I'm doing activities. I'm doing things like this. So pain is a very personal experience. And so a lot of them will trade increased activities, maybe increasing their pain, if that's their quality of life they're looking for. So my 2 cents worth is to be careful of just chasing pain. It should be up to the individual patient what they think is the better quality of life for them. Sometimes it is more pain reduction, but most time it's that functionality. Thank you.
Okay, thanks again, Dr. Tinkle. So again, we'll have about 10 minutes for any questions from the audience. Just wait till the microphone comes to you.
Hey, thank you. I saw that core temperature regulation was on one of your slides, and I was just wondering if you see any correlation between these kinds of things and things like Raynaud's syndrome.
Raynaud's? Okay. So what was the first part? I have one hearing aid out because this microphone, so it's sometimes a little harder for me to hear. You said Raynaud's and what?
Just temperature dysregulation.
I'm sorry?
Temperature dysregulation.
Oh. Mm-hmm. So Raynaud's really is more of a rheumatologic problem. A lot of people come in with that acrocyanosis, the blueness, but definitely with temperature dysregulation, et cetera, you can get cold, white hands, you can get flushing hands, you can get more of the purplish hands where the blood is there. It's just now deoxygenated because it's not moving anywhere else. So that can look like Raynaud's, but it doesn't tend to always have that fiery pain that Raynaud's should be having. And the reason why I try to make that distinction, a lot of people come in with, oh, you got blue hands, you got Raynaud's. The treatment for Raynaud's is a calcium channel blocker. which can lower your blood pressure, which can make the pot stuff worse. So that's why I'm always very careful of, let's just make sure it's blue hands versus Raynaud's. If it's Raynaud's, then I send them off to rheumatology, but with a caution as we don't necessarily want to do that if we don't have to. Is that, okay.
Hi, thanks for the talk. I was just fairly recently diagnosed. I'm in my 50s now, and I also happen to be a childbirth educator. And so it's interesting because, of course, had I known a lot more earlier through my own pregnancy and everything, I, would have a different outcome now, possibly. But in my classes, I often see women who very clearly have not been diagnosed or don't even make a connection between their hypermobility, and they come back to classes telling me stories about how the birth went, and my scope of practice as a childbirth educator is not obviously to say, have you talked to your doctor about hypermobility, but oftentimes somebody will say, this happened in my labor, and I'll say, do you happen to have hypermobility, or are you double jointed? And, oh yeah, I am. Oh yeah, so is my mom. And so is there anything you would suggest for me that I can offer to the people in my classes to sort of maybe point them in the right direction to be getting, I definitely talk about pelvic floor health and getting in to see someone before or after the pregnancy. Before is preferable, but any suggestions for what I can do or say?
Sometimes educating other professionals gets to be kind of a task. A lot of people who don't want to feel like they want to push on the other professional, give stuff to the patient, like a pamphlet, maybe it has the Biden score, and they can go to the professional and talk about it. Because it's one of those things, even in my book, I talk about how to talk to other professionals, because if you want them as an ally, education can be done. Somebody who's willing to work with you is gold. And so you want to sort of do that. And if they just don't know what to look out for, then sometimes just a simple, hey, here's a little flyer on the Biden exam and some issues on joint hypermobility. Once you take this and discuss it with your doctor, most time if they're one of those who will listen, they'll stop, think about it and stuff like that. For the others who feel like they're being asked too much, they're going to tell you to go away. Chances are that's not the person for that patient, unfortunately.
Thank you for your presentation. I was hoping you could expand on that comment you made about the different diagnoses. You said something about benign joint hypermobility syndrome or joint hypermobility syndrome or hypermobile EDS. And then you said something about how there's one of those diagnoses that you prefer to use. So I was hoping you could expand, please, on those different diagnoses.
Yeah. So part of the reason why HEDS was redefined in 2017 was the US federal government labeled it a psychological condition. And there's, at least in the US, and probably from other professionals, et cetera, they don't look for hypermobility. They don't think hypermobility is a problem. What I got taught in medical school, if you were hypermobile, that was a sign of fitness. Doesn't matter if you're 300 pounds and can palm the floor, that was fitness. And it's like, that doesn't make sense. And then plenty of orthos I would see, they'd operate on the knees. It's like, did you ever think the reason why you're having to operate all the time is because there's ligamentous laxity, hypermobility? And it just puzzles me and others why the doctors are not recognizing that. So, but we would get pushback and say it doesn't exist. And so that's the reason why we were looking for more things that we could objectively put on there. But unfortunately, because there's not a lot of money behind EDS and those kinds of things, there wasn't a lot of great data. And the things that we wanted to use, like dysautonomia, pain, functional gastrointestinal issues, were poo-pooed by the other professionals who were even still part of the process. They didn't think they were specific enough to help with the diagnosis. So we were left with, okay, you're bendy, you got some problems with it. Maybe your soft tissue has problems with hernias or itises and et cetera. And so it's still a challenge. It's going to go through a revamping here probably in the next 2 years. Obviously, everybody is wanting a genetic test. I'll tell you, I'm scared for genetic tests because I think any gene they find is going to explain 5% of the population. And then now 95% is going to be labeled something totally different, but 5% are because we're too quick to believe tests and not the patient. So the hypermobility syndrome hasn't had the same political pushback on it. Some of that comes from, if I'm a geneticist, I get told to my face, I know nothing that doesn't come from a genetic test. And so it's one of those things, no, I'm a doctor first, geneticist second. So it is one of those things that rheumatology, as adult people dealing with a lot of joint issues, that was in their ballywhack to sort of take care of that stuff. A geneticist, what do we know to diagnose it unless there's not a blood test associated with it? And so there was a lot of resistance to that name. I don't know the resistance is going to be overcome by putting new criteria down. We kind of made things strict in 2017 to get more people to believe in it. That seems kind of contrary, but it's like if we make everybody look the same, then I can march them in front of a bunch of medical students and doctors and say, don't you see the pattern here? But if everybody's very different, I pull a 6-year-old who's contorting and I pull a 40-year-old who's very arthritic and stuff because of hypermobility, they're not going to see the connection. So hypermobility syndrome to me sometimes is just nice to plug them in and say, this is what you have. And the criteria a little bit more straightforward. The only problem is its formal name is the benign joint hypermobility syndrome. So most people think it as just a benign condition, but I try to remind people that the original criteria is chronic pain. We don't call chronic pain benign.
Perfect. Thanks for all the good work that you're doing. Question, do you know if anyone's looking at APGAR scores at delivery and whether there's any role of some of those more features in that testing spectrum around prevention in the hypermobility landscape?
The APGAR scores? I don't know if anybody's looked at it. It's nothing that's ever stood out to me. Because again, as a pediatrician, we're sort of looking at birth history and those kinds of things. So like I said, nothing's really stood out. And of course, I see a lot of other kids with birth defects and et cetera. So I'm constantly seeing those issues. Usually if there's any depression, the birth scores is maternal mother condition. And it can be POTS is one of the things that we do talk about, that if you pop an epidural in there, blood pressure can go low, the baby starts stressing, has meconium, and so they can come out looking kind of sick, when we probably could have prevented that to make sure there's IV fluids going, because a potential C-section, what do? Not eat, not drink. One of the bad things you can do for POTS. And so we always make sure if they get an epidural that they usually get fluids also. And so I don't know a specific one, but thanks for the thought. I'll keep that in more mind when I take a look.
Okay, from the virtual audience, there's a couple questions actually from several people about congenital torticollis and plagiocephaly, and if it has any kind of correlation with EDS.
What was the cephaly part?
I might not be saying it right. Plagiocephaly?
Plagiocephaly. So I'll deal with that first. Plagiocephaly is just an odd shape to the head. Most common in newborns, it's greater just positioning on the back, and they get a side preference and they lay to one side, so one side flattens more. It has been associated with hypotonia, lower muscle tone, and lower muscle tone can be associated with hypermobility. So we do kind of see some of that together. But for my hypermobile ones, not something I typically see in again in their birth history or anything else. And I've already blanked on the first half of that question. I'm sorry.
Torticollis.
Torticollis. Torticollis a lot of times is more position dependent. There can be some developmental things, but a lot of times if the baby's squished in there, then this muscle is going to be shorter than this muscle, and it's going to affect those things. So again, it's not something I would typically see. I've seen as many as I do. Yes, I mean, I've seen it, but it's not such a common thing that I think it's really part and parcel of hypermobility.
Okay, Maybe just one more question from the online, or was that it?
I think there was another, just a sec. Oh yes, it was about the jaw and the face. Sorry, they go all weird order. Oh yeah, is there any research being done or that is done on orthodontic treatments reducing TMJ syndrome?
So some of my teenagers that I don't see the jaw problem is because they're having braces. A lot of times they have bands, which help limit their jaw motion. Sometimes they also may be socially anxious about showing their braces and et cetera, and they may not open their jaw as much. And so I'm not sure exactly why, but occasionally when I have them go off braces, and sometimes they go to retainer or nothing, I'll have the orthodontist put those bands back on to give them some resistance so they're not opening their jaw. Because for most people that are hypermobile, you use your joints how you just naturally use them. And if that means opening up your mouth this big, that's not as like good for your joint, but that's just normal for you. And so sometimes we got to restrict that. So I've seen orthodontic work actually improve the jaw symptoms. But of course, when it comes off, then the jaw symptoms eventually return.